شكرا يا سليمان. I know we are going through difficult times بخصوص الكورونا to make a large national meeting about hypertension is a big challenge. تحدي كبير ان احنا نقدر نعمل مؤتمر في الظروف الحالية. My assignment مهمتي ان just to review quickly about the information that should be provided to the cardiologist regarding the practical management of hypertension. I'll address the following points: the diagnosis, the laboratory evaluation, and then when to initiate drug therapy, which is a very critical question. Just a few words about current and future therapy, and how to improve patients' compliance, which is another challenge. And finally, a few words about our Egyptian Hypertension Society guidelines. Regarding the diagnosis, which might be looking confusing, but quickly, what is new in the recent international guidelines? Recent international guidelines بتقول إيه؟ They stress the importance and the need of using out-of-office measurement of blood pressure. يعني بيؤكدوا أهمية قياس الضغط برا عيادة الدكتور. Diagnosis of hypertension based على 2 measurements at visit or 2 occasions will not be enough to sustain a diagnosis of hypertension. فتشخيص الhypertension is more complicated and is not just simply checking the blood pressure a few minutes, even if you repeat it, is not enough. Another new thing is that mercury sphygmomanometers are not welcomed, where new guidelines do not encourage the use of the mercury sphygmomanometer. The British guidelines recommend, before making the diagnosis and before starting treatment, is to use ambulatory blood pressure measurement. Of course, this may not apply, may not be applicable to the situation in our country. This is the recent guidelines of the European Society putting definitions of hypertension, and you have the optimal blood pressure, the normal blood pressure, the high normal blood pressure, and we have hypertension. The optimal is less than 120/80, the normal 120, 129, 80, 84, the high normal 130, 39, 85 to 89, and hypertension is 140/90 or more. So this is almost the recent classification of the blood pressure. And for each of these categories, for each of these classes, the follow-up will depend whether it is every 5 years, 3 years, annually, or days. This is more simple classification. For less than 130/85, we measure the blood pressure within 3 years, and 1 year in those with other risk factors. In the range of 130, 159, 85, 99, if possible, we confirm the out-of-office blood pressure measurement because of the possibility of white coat or masked hypertension. If this is not possible, then we have to do repeated office blood pressure measurements. 160/100 or more, we have to confirm this within few days. Now, we discovered that this individual or this patient is hypertensive. What is the next step? The next step is to confirm the diagnosis by repeating blood pressure measurement. Then, following that, we go through laboratory evaluation. Then we advise the patient about lifestyle modification and initiate pharmacologic therapy, which is a critical decision, and lifelong blood pressure monitoring. So to diagnose or to commit a patient having hypertension is not easy. First, treatment. He might need treatment for the rest of his life, and he will need lifelong monitoring. Why repeat blood pressure measurements? These are data which we did some years ago on the National Hypertension Project, and we measure the blood pressure on 2 separate visits, 2 separate occasions. And you can see in the first visit the number of hypertensives, and in the second visit, which was done on the same individuals, the same patients, by the same doctors, in the same environment, how those that were initially diagnosed as hypertensives in the second visit, there turned out not to be hypertensives. This is an interesting study where the blood pressure was measured every week for 4 weeks and then at monthly interval. At the initial measurement, the blood pressure 160 and 100 diastolic. After 1 week, second visit 152, 97, and over the following weeks, it dropped till it settled by the 4th week. So blood pressure is variable, it can decrease, and this is important before making the diagnosis of hypertension. The next question is about laboratory evaluation. Why we do laboratory evaluation? We do laboratory evaluation simply because we want to identify the global risk profile of the patient. We don't identify other risk factors. We want to identify high-risk patients through detecting risk factors, assessing target organ damage, and diagnosing associated cardiovascular or renal disease. And another objective, which is not that important, is to identify secondary causes of hypertension and comorbid conditions. We have to realize from the beginning that blood pressure alone is a very weak predictor of cardiovascular risk. The seriousness, the danger of hypertension does not come simply from the numbers that we measure. It comes also from the global risk profile. And in this study, the probability of coronary heart disease in 2 groups of individuals, those who are at low risk, non-smokers, no glucose intolerance, no ECG LVH. And the other group, cigarette smokers, glucose intolerance, LVH. Now look to the probability of coronary heart disease at the same level of the systolic blood pressure, 165, and at the same degree of elevation of serum cholesterol. In the high risk, 165, the probability was about 30%, while in the low risk group, it was about 10%. What laboratory tests we order? Of course, because of our limited resources, and we are not a rich country, and our patients are relatively poor, so we cannot do a very detailed laboratory evaluations. But there are essential tests that we need in all patients, including urine dipstick for protein, blood and sugar, and blood tests for sugar and creatinine. But if facilities are available, and this is the ideal, this is the recommended, we should look for lipid profile, uric acid, serum potassium, hemoglobin, ECG in patients with severe hypertension. These are our guidelines. One important objective of this laboratory evaluation is looking for cardiovascular risk factors. And this is very important. As I have mentioned earlier, the seriousness of hypertension is not only in the numbers, but also because of the associated risk factors, such as diabetes, the gender and age, the total cholesterol, more than 240, HDL less than 40, and LDL more than 160, cigarette smoking, obesity, serum creatinine more than 2 milligrams, the presence of metabolic syndrome, and family history. These are the cardiovascular risk factors. These are the risk factors which we'll be looking for and searching for. And based upon these risk factors, we can categorize our hypertensive patients into 4 groups. Low risk, these have no additional risk factors, no target organ damage, no associated atherosclerotic cardiovascular or renal disease. And unfortunately, these low-risk patients constitute less than 20% of the hypertensive patients, because in more than 80% of hypertensive patients, there are other cardiovascular risk factors. Moderate risk, 1 to 3 additional risk factors. High risk, more than 3 risk factors, or target organ damage, or diabetes or renal failure. Very high risk, these are patients with symptomatic cardiovascular disease, those who develop coronary disease or heart failure or stroke or aortic aneurysm or peripheral arterial disease. Now we come to initiating treatment. This is a very critical question, because once you make the decision to initiate pharmacologic treatment, this means that you have committed your patient to take for the rest of his life, almost every day, drug therapy. This is one-way traffic, ده طريق بلا عودة. So this should not be taken lightly, ما يؤخذش باستخفاف, just to initiate treatment, because there is no cure from established essential hypertension unless the rare condition the patient develops a big stroke or massive infarction. We start and continue with lifestyle modification. Weight is an important target, and 5 kilogram over 4 to 6 month weight reduction is ideal. Physical exercise, just simply brisk walking, 30 to 60 minutes, 5 days per week, limiting less salt intake to less than 5 grams of sodium chloride, healthy diet rich in fruits, vegetables, stopping smoking, and controlling stress if possible. Pharmacologic treatment. Initiation of drug therapy depends upon 3 things. The first, as I have mentioned earlier, the global cardiovascular risk profile. Are we dealing with high risk, low risk, intermediate risk? The second factor that will determine the initiation of drug therapy is the level of blood pressure, and finally, the response to lifestyle modification. When we are justified to give drugs on first office or hospital visit, the first time you see the patient and you start initiating drug therapy. This is again according to our guidelines. If there is a hypertensive emergency, or if the blood pressure is greater than 210 over 120, 3 consecutive measurements, 2 to 3 minutes apart, and you are excluding a panic attack, because during a panic attack, the blood pressure can go very high. You know what is meant by panic attack? Now, panic attack, very severe anxiety. Time will not allow me to go through the details of panic attack. Or of the blood pressure greater than 180 over 10, 3 consecutive measurements, 2 to 3 minutes apart, in presence of target organ damage, symptomatic cardiovascular disease, or chronic kidney disease. These are the Canadian guidelines, the CHIP, the Canadian Hypertension Education Program, and they put the office threshold for initiation of pharmacologic treatment. In high-risk patients, according to the SPRINT population. SPRINT population, this was a population of hypertensive patients over the age of 50 with risk factors, and they used a special technique for checking the blood pressure through the automated office blood pressure measurement. And this gives readings generally about 10 millimeter less than the usual office readings. For this population, the threshold for initiation, 130, systolic. For diabetics, 130 over 80 or more. For moderate risk, that's 1 to 3 risk factors, 140, 90. And for low risk, no target organ damage or cardiovascular risk factors, 160 over 100. What are our blood pressure targets? According to our guidelines, we are a bit conservative because we know the limitations of our patients. So we were not aggressive as in the European and American guidelines. Less than 150, 95, These are in low-risk patients, and less than 140/90, 2 risk factors more, or in diabetes or chronic kidney disease or target organ damage, less than 130/80. If there is heart failure, chronic kidney disease with proteinuria or diabetes associated with proteinuria. Pharmacologic treatment, which drug to choose? Because we have a long list of drugs and we have different groups of pharmacologic agents. The selection of the drugs will depend upon the presence of any compelling indication for a specific pharmacologic group. What's meant by compelling indication? If the patient has coronary disease or heart failure or diabetes or kidney disease or associated comorbid conditions. In patients with more than mild hypertension, 160/100, and high-risk patients, it is recommended to initiate therapy with a combination of 2 drugs. Now we have single pill that contains 2 drugs. So in this situation, 160/100 or more, we give a single pill drug combinations. The selection of the first-line therapy should be individualized. For example, in coronary disease, angina, beta blockers, plus minus calcium channel blockers or RACE blockers, myocardial infarction or CABG, beta blockers plus minus ACE inhibitors or ARBs. In heart failure, diuretics plus minus beta blockers plus RAS blockades plus spironolactone if necessary. In atrial fibrillation, beta blockers, non-dihydropyridine, calcium channel blockers, RAS blockers. In cerebrovascular disease, RAS blockades, calcium channel blockers, diuretics. Peripheral arterial disease, RAS blockades, calcium channel blockers. In diabetes, the antihypertensive drugs of choice are RAS blockades plus minus diuretics. In presence of renal disease, we give RAS blockades, diuretics plus minus calcium channel blockers. Again, here I'm stressing the fact because many of us feel reluctant, they hesitate, they do not like, they stop the RAS blockade in patients with renal disease. On the contrary, in patients with renal disease, we give RAS blockade because they have a renal protective effect. How do they produce renal protective effect? Because they reduce the intraglomerular pressure. Why do they reduce the intraglomerular pressure? Because they have a more vasodilator effect on the efferent arterioles. In isolated systolic hypertension, which is common in the elderly, the drugs of choice, calcium channel blockers plus minus diuretics. If there is left ventricular hypertrophy, RAS blockade. For cardiac surgery, beta blockers. In presence of migraine, tremors, anxiety, beta blockers. Pregnancy, methyl dopa, calcium channel blockers. Prostatic hypertrophy, alpha-adrenergic blockers. These are, again, the European guidelines. In initial therapy, they give a single pill combining ACE or ARB plus calcium channel blocker or diuretic, but you can give monotherapy in low-risk patients or if the systolic pressure is less than 150 and in the very old. If it does not work, you move to step 2, you give triple combination, and if this is not working, this will be a resistant hypertension, you add spironolactone or other diuretics or alpha blocker or beta blocker. These are the different pressure mechanisms. We have, or at least we recognize, we can identify 4 pressure mechanisms that are responsible for hypertension. Sympathetic overactivity, increase in the blood volume, which we call it the sodium factor, increased arterial stiffness, and the renin-angiotensin system activation. And for these pressure mechanisms, we have the drugs that will attack these pressure mechanisms. Just future drug therapy. At this stage of knowledge, still we are not 100% satisfied with the available drugs. And there is ongoing research for developing more effective drugs, for drugs that can also handle the other cardiovascular risk factors, for drugs that have limited side effects. And just quickly, this is a quick list of the future drugs: mineralocorticoid receptor antagonists, phenyrenone, aldosterone synthase inhibitors, activators of angiotensin converting enzyme 2, aminopeptidase inhibitors, dopamine beta hydroxylase inhibitor, angiotensin receptor neprilysin inhibitor, which is available now as Entresto, and vasoactive intestinal peptide receptor agonist. A very important question is to improve patients' compliance. Now we know hypertension is a silent disease. We know that hypertension has no symptoms. We know that treatment of hypertension should continue indefinitely. So the patient generally will stop taking the drugs. And in this study, which we did some years ago, almost 2,000 Egyptian patients, and in just 1 year time, about 80% of the Egyptian hypertensive patients stopped their antihypertensive medications. 80% من مرضى الضغط المصريين في خلال سنة بيبطلوا علاج الضغط بتاعهم. So we have to look for measurements that will improve the patient's compliance. We have to educate the patients that hypertension is silent. ما فيش كلام فاضي، الصداع ووجع في الدماغ والتنميل وعينيا مش عارف بتزغلل وبتاع، ده كلام فاضي. These are symptoms of anxiety, مش hypertension. Hypertension is silent disease. It does not cause headache unless there is hypertensive encephalopathy or very hypertensive complications. Hypertension is dangerous if not treated. It requires lifelong treatment and lifelong monitoring. We have to prescribe affordable drugs. العيان ما قدرش يشتري الدواء فبالتالي هيبطله. And if you give a drug, it is recommended that to be given just one daily, أقل عدد ممكن من التابلets and single pill combination. And finally, about our Egyptian Hypertension Society. 7 years ago, we developed the third version of our guidelines. And we need our Egyptian guidelines. Why we need our Egyptian guidelines? Because universal guidelines may not be reliable because countries vary in the availability of health care and economic resources. Furthermore, populations differ according to their genetic predisposition, their response to medications, and risk profile. So the Egyptian guidelines, an important element was cost containment. We limit laboratory workup to the most necessary ones. We stress the importance of lifestyle modification as an essential element in the management. No drug therapy in low-risk patients if blood pressure is less than 160 over 100. Initiate therapy with least expensive medications. Avoid prescribing unnecessary medications. Limit office visits to the necessary. When the doctor finds that his patient has high blood pressure, these are practical issues in our guidelines. Is his patient truly hypertensive? حقيقي عنده ضغط? Not simply white coat or isolated office hypertension مجرد ان هو لما بيروح الدكتور ويتشد ضغطه بيعلى. How many times you check the blood pressure and on how many occasions before making the diagnosis? How to measure blood pressure accurately? This is very, very important. What level of blood pressure defines hypertension? And what are the necessary laboratory investigations? What is the role of home and ambulatory blood pressure measurement? And is the patient in need of drug therapy? When to initiate and how to select initial therapy? When to start therapy on first office visit? What to do if there is unsatisfactory response to therapy? What to do about blood pressure variability? Blood pressure fluctuates. It fluctuates, it changes from 1 minute to another, from day and night, from summer and winter, and what to do about it? How to follow up the patient with high blood pressure, improving compliance and hypertensive emergencies, and when to suspect secondary hypertension. So in conclusion, the diagnosis of hypertension should be based on out-of-office measurements, if possible. In the office, it is recommended to use automated office blood pressure measurements or repeated measurements. The threshold and target blood pressures are lower in those at greater risk. So it is mandatory to identify the risk profile of your patients. You have to individualize the patient to meet patient needs. 4 classes of drugs are available now: diuretics, calcium channel blockers, ACE and ARBs. You have to simplify drug regimen using long-acting drugs and single pill combination. And at this stage, treatment is still empirical, and we need future drug therapy. And thank you for your attention.
شكرا دكتور محسن، حضرتك كالعادة يعني محاضرة دسمة. حضرتك بتستخدم في الاكتشوال لايف، يعني في العيادة بتاعت حضرتك انت، الدياجنوز بانهي أجهزة؟
I'm still from the old school, and generally I check the blood pressure through an automated device and mercury sphygmomanometer. Why is that? Because in arrhythmias and atrial fibrillation, you need the mercury sphygmomanometer.
أي أسئلة من الفلور؟ أي أسئلة للدكتور محسن؟ شكرا يا بيه، حضرتك شاكرين جدا. في سؤال هنا تاني، فين؟ اتفضل. معلش يا دكتور محسن، انا آسف جدا، حضرتك في سؤال. اتفضل.
Thanks, Prof, for your elegant talk. I have just 2 questions. The first questions.
ممكن تقدم نفسك بعد إذنك؟
أنا الأستاذ دكتور نور الدين الجابر، أستاذ أمراض القلب في جامعة صنعاء.
حضرتك منين؟
صنعاء.
من صنعاء.
أهلا وسهلا. أهلا وسهلا. أهلا وسهلا.
So the first questions, for which limit we are going to use SA inhibitors in renal disease? Should we continue whatever it will be, the creatinine or creatinine clearance? The other,
الصوت مش واضح قوي.
so for which limit you are going to use SA inhibitors in renal disease? Shall we continue whatever it will be, the lab test or the renal or the patient's symptoms? The other questions, what do you think for our countries? The new American guidelines is more applicable, or the European or Canadian guidelines? Which one of them is suitable for our countries to be used? Thank you.
Okay, thank you for your questions. 2 important questions. I will answer first the second question. Use the Egyptian guidelines. So this is the response to your second question, which guidelines to follow? The American, the European, the Japanese, the Italian, the English? We recommend the Egyptian guidelines. Unfortunately, the Egyptian guidelines were not updated, but I need your help, your feedback to update our Egyptian guidelines. The first question regarding patients with chronic kidney disease and ACE inhibitors. If your hypertensive patients, you give him an ACE inhibitor, his serum creatinine, it is expected to go up a little up. Why is that? Because you are reducing the intraglomerular pressure, so you are reducing the filtration. This is expected. But when the increase is marked, when it exceeds more than 50% the baseline, then you have to suspect the possibility that this patient has renal artery stenosis. And you have to confirm this by more investigations. Okay?